Well, good afternoon, everybody, and thanks very much for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Belden. I'm the Director of Emergency Preparedness. Today is January 29th, 2021. It's 1 o'clock in the afternoon. And for this week's webinars, we're going to cover, actually, it should just say AFL, because there's only one that we're really going to cover here in this presentation. Then we're going to go over some morbidity and mortality weekly reports from the CDC. It's highlighted some things that may or may not come up within your facilities, but I wanted to make you aware of it if you've not seen these reports. And then we'll talk about vaccine issues ad nauseum. And I suspect this will be a standing topic for a while here. So with that, let's get started. I want to say thanks everybody for joining us. And I realized that the beginning intro of these presentations all begins to sound the same. Hopefully I was thinking about coming up with some music or something to ease us into the program, but I think it'll get pulled off YouTube if we do that. So anyways, with that, we'll stick with our same boring intro here. The speaker's opinions expressed are their own. On this particular webinar, it's just going to be me. Patty has a conflict, so I'll cover the AFL for you guys. When we talk about things, they may not reflect CAF's official position, and this is a grant-funded program that brings these webinars to you. I have no financial conflicts. I'm employed by CAF. The intent of the webinars is to provide you a situational report and give you awareness of things are happening within the community as it relates to COVID. We'll talk about forecasting, where we see things going, and highlighting best practices where we can. All right, so for the first AFL, it's really kind of a repeat or a reinforcement of the requirement to maintain staffing levels. And this is if you ever wanted to know, how impactful labor is in California, you can look at these really pushes to make sure that staffing levels are being met during the coronavirus response. And we've got ad nauseum explained to CDPH that 3.5 and 2.4 are difficult for folks to meet in the best of circumstances. And when you add hundreds of hours of staff time on top of jobs or functions that we already do that we cannot stop doing, it compacts the amount of time that we have to be able to spend actually providing care. And it's a real issue, and it's a disconnect between what the state sees as adequate staffing levels and what you guys understand as being adequate. I know the two do not compute, and we have to do our best at trying to explain that to them. And we have ad nauseum. Sadly, I'm not sure it's going to get much better. What CDPH has basically said is these temporary waivers should be as a last resort, and they're going to really verify that you have gone through all of the elements to receive staffing prior to approving any temporary waiver. We've fought tooth and nail for this, and we will continue to do so. It's innately unfair to not understand the amount of time that it takes to document all the things we have to do, new regulatory compliance, donning and doffing of PPE, all the different added elements to doing our job are added with no understanding of how much time that takes to accomplish those things. So we continue to advocate on your behalf and let folks know that. In their interim, though, we do expect CDPH will monitor the SNFs that have temporary waivers to continually assess whether they're necessary. And whenever they put a language like may do unannounced audits, I always say that will do unannounced audits is probably a more appropriate term. So if you have a temporary waiver, expect to be asked those questions to justify an ongoing use of that waiver. And as a kind of reminder, if you have questions about how to submit a resource request for staffing, there's an AFL that describes that. And I realize, you know, the MOAC process, CDPH thinks it's a streamlined process that works every single time, and we realize that's not the case. We want to continue to document those cases when you have them, where you're either being denied staff, or the staff that come are not the staff that you need. Consequently, they would not be counted in 3.5 or 2.4. They don't fit in one of those buckets. We like to track all that information. It just gives us more data to provide to CDPH to say, look, here's the problem that it exists, and this is where, and this is how we can fix it. So we continually look for those pieces of advice or guidance from you guys to be able to tell us what is not working. So I know folks have reached out to Patty. I want you to continue to do that. If you have issues obtaining that staff, or with temporary waivers being declined, or the 5,000 A's being declined, let us know those so we can track them. We can kind of try to identify what are the things that CDPH is looking at that will automatically reject these waivers. So, and if you have questions, obviously the AFL is listed there. It's AFL 2107. All right. Let's move to the next section here and talk about some of these morbidity and mortality weekly reports. For those of you that don't know, and I think most of your infection preventionists probably have bookmarked these websites, but if not, I highly suggest, if you're an IP or if you're an administrator, to tell your IP to make sure in their kind of weekly review of subject matter and improving your situational awarenesses, I would review the MMWRs that come out every week. Here's a link to the one that came out on January 15th. And this one is important to us because Candida auris is a very nasty virus. It has been found in skilled nursing facilities within the state of California. There's a few states that have had outbreaks of CRS. There's a really high mortality rate associated with CRS. Now, there was a CRS outbreak in a COVID specialty care unit. This was in a hospital, but it was set up for long-term post-acute kind of needs for these COVID recovering people. In that unit, they had 67 COVID positive people, and 35 out of those 67 tested positive for CRS after the outbreak. So when it gets in a facility, it moves pretty easily. Some of the things that were, and the reason why this is important, because I want you to identify to see if you guys are actually doing these actions within your COVID units or your red zones, and make sure that you're not making some of these same mistakes. So one of the things they identified with the investigation of the outbreak was that healthcare professionals in the COVID-19 unit were observed wearing multiple layers of gowns. So that's 2 gowns and 2 gloves. And what they were doing is they were leaving one gown on for extended use, and then just putting a gown over that, and gloves for extended use, and using alcohol-based hand rub to clean the gloves, and then don with a second pair of gloves. So those 2 combinations of double layering for gowns and gloves were the primary source of what they thought was cross-contamination. They identified a combination of factors, and those other factors, that's essentially what we're already doing. We know that there's potential for lapses in cleaning or disinfection of shared medical equipment, lapses in adherence to hand hygiene. You know, those things are going to stay the same, but if you're trying to go to or using double layers in those COVID-19 units, the CDC definitely recommends away from the use of more than one isolation gown or pair of gloves at a time. And there's a link to that specific report that goes into more depth on the specific lapses in cleaning and disinfection, especially of shared medical equipment. It's, you know, if you think about, you go into a room, but you have medical equipment out in the hallway and you've doffed, and now you're wearing that same extended use PPE as you touch those shared medical equipment. And so that was another point that you can kind of take a look at within your facility and make sure that folks are paying attention to that shared medical equipment as well. So I wanted to make you guys aware of not only this particular thing, but the MMWRs as a whole. I know I spoke about it last week in relation to the Moderna MMWR, where they reviewed the first doses of the first 4 million doses of the Moderna vaccine. And I talked to you about the kind of reports of adverse events after the receipt of the first dose. And there's a link to that specific report, and it holds pretty consistent. 0.03% have been reported into VAERS as having adverse reactions. In terms of the Pfizer vaccine issues, I just want to make you aware, if you've not heard, chances are you probably heard about it in the media. There have been a couple of healthcare worker deaths associated with the Pfizer vaccine, one in Orange County and another physician in Florida. There may be others. Those are the two that I'm aware of, and they're in the national press. So expect your staff and folks to see that and have questions about that. I always say we want to address the messaging with transparency, but a lot of that will require on you being able to competently explain those specific scenarios. Now, the death in the healthcare worker in Orange County, well, both of them are being investigated by the CDC, obviously, but we have less data, or I have less data on the healthcare worker death in Orange County. So we don't know if that's truly can be associated with the vaccine or not. But the other one in Florida, I read a pretty lengthy article about the conditions that it presented and how it developed. And the article interviewed a number of other epidemiologists and vaccine specialists and other physicians that all felt that what had happened to that individual physician was most likely as a result of the vaccine. So in some rare cases, that may happen, and it may present in other cases. The CDC has done an MMWR on Pfizer. Now, it does not include those healthcare worker deaths or any other deaths, but it does show a similar type of response as the Moderna vaccine. In the Pfizer's case, there were 0.2% of the doses were reported with adverse effects. It's not a significant number, but still, it does definitely, there is a possibility for adverse effects. Now, most of these are all relate to anaphylaxis, and that's consistent with the MMWRs if you read them. We still don't have 100% data as to any other deaths that may or may not have occurred. When they did the original, EUAs, neither one of them had any deaths related to the vaccine as a part of this. So these are obviously new conditions that we'll have to pay attention to, and expect your staff that maybe, may have caused them to have pause in this effect. And I will say that, we've got somewhere in the neighborhood of 50,000 skilled nursing facility staff that have tested positive for COVID, and roughly 200 plus have lost their lives. And it's still I still think it's an effective way to protect ourselves, and if we happen to be able to protect our residents with it, I think it's a worthwhile endeavor. So hopefully you guys can be able to meet that messaging with transparency. And I know not everybody's they're gonna go, no, I'm gonna pause now. Thanks very much. And just to know personally, my wife and I both got the vaccine this morning, And so, you know, we're doing okay. So we'll keep going. And I definitely practice what I preach in my personal life and with my family. So I encourage you guys to do the same. All right. I want to talk about another MMWR because we had brought on a company to talk about running your own testing clinics. I'm not sure if anybody has reached out to those folks, but as we look at forecasting for long range testing needs, given the extraordinary cost of continually using PCR testing, I think at some point it's likely that the state is going to look at more cost-effective methods for ongoing ability to test for coronavirus. And one of those testing modalities that I think that CAF will want to encourage the CDPH to really kind of wrap their heads around is the Abbott Binax Now. And I know other folks are using other antigen testing devices, and certainly if you feel like those are better, let us know that so that we you know, keep those in the realm of possibilities. But I think this antigen testing is something that we're going to move towards. The good news is it does have high specificity, so that when there is a positive test, it's usually accurate. And those tests can be really pretty darn effective, especially given the fact that we can use these tests in a much shorter period of time with much shorter turnarounds than the PCRs. And I think as an ongoing testing, long-term testing strategy, when we look at, you know, do we want to continue to pay $100 per PCR test or $4 per antigen test? And it won't be long before the purse strings start to tighten from a PCR testing standpoint. And it may be possible where we don't have the ability to have that paid for. And if it is, we want to at least develop our capacity and our ability to utilize these antigen testing devices if that's what the state goes to. So I wanted to give you the information about they're a little more effective than we had originally thought. And given the combination of increased performance with as we have increased competency with the actual kits, it will and the amount of time that it takes us to get those results back, I think we're finding that they're just as effective, maybe even more so by having that short turnaround time. So we want to, if you've not already done this, I highly suggest that you develop the capacity to be able to do one of these antigen testing devices. All right. So the last kind of MMR I wanted to talk to you about were kind of rates and an overall look of COVID rates among residents and staff members in nursing homes. And these are trends that were reported over a really long time frame. So from May through November of this year. So it's a really long time that we get to take a look, and we kind of take out some of the kind of surge numbers to get a realistic look of how exposures are happening inside of nursing homes and what is contributing mostly to these outbreaks. And if you look at that bottom bullet point, greater than 34% of the high-risk exposures occurred among healthcare staff members involved in non-patient contact. So that means something outside of work. So that would lead me to believe that you know, we need to double down on our education for our staff to let them know their you know, what the essentially guidance for how to protect yourself at home as well as at work, and you know, double down on the use of masks if they're not. I think folks, you know, I go out in public quite frequently. I don't see anybody without masks on anymore, or very rarely. So I think folks are down with that, but the social interactions and physical distancing from people while you're socially interacting is a difficult thing to approach with your staff. But just know that 35% of the exposures are happening outside and they're bringing it inside. But that also leads us to believe that 65% or thereabouts, um, the high risk exposures are coming from within the facility, which makes sense in a COVID positive unit, but it may not make sense in other parts of the building. And so there wasn't much data that was given to really dive into the, what within the healthcare facilities presented the most risk. Was it having red zone people, in the same building, or was it, were there other contributing factors? And I think as we go forward, when we talk to CDC about doing investigations, we really want to dive down into what within the facilities, where were those exposure points? Was it, staff and residents, or was it staff congregating in break rooms, or what was it? Lack of IP or infection prevention and infection control. There are a lot of things that can go into that other 65%. But for this 35%, we know kind of the messaging to give to our staff to encourage that. And I want to encourage you guys to share that with them, so that they, aren't at risk of bringing it in to the building. So, all right. And I want to kind of, I know we've got really a short amount of information this week, which is good because not a lot is changing. But I wanted to mention a couple other things. Disasters happen even during pandemics, and as a tool of situational awareness, and that's generally what we call it in emergency management, is having situational awareness about the community that you live in, the geographical area you live in. All of those things are really hard to keep your eyes on while you're involved in everything COVID. And it's really difficult. Now, maybe some of you have heard, of the notifications, and maybe you have been affected personally at your home. But with all this rain in the burn scar areas, it presents a very significant risk of floods. We don't have to go far to see the impact of that. Even on skilled nursing a couple of years ago, after the Thomas fire, there were the floods in Santa Barbara County. And so things like this happen, and we may be fully involved in an outbreak in our facility, and Mother Nature does not see that. It's just going to happen when it happens, and we have to, one, be prepared for that, and we have our plans in place, and hopefully you feel confident in being able to meet that. But in terms of knowing, what are the risks, and how do I keep my eyes on certain things when so much is going on and there's so many places to look for resources. Now, I am a member of the Care Resiliency Alliance, and and this is a free program, and I highly recommend each and every one of you become members of this. The Care Resiliency Alliance is made up of a bunch of different stakeholders, not just from healthcare. It's all over the business community within California. But these folks send out weekly listservs that kind of list out a lot of these things. They send out updates on public safety power shutoffs and where it's going to be impacted, and links to get to it. They really do a fantastic job of rolling a lot of stuff up into a really good situational awareness report. And as a bonus, for those of you that have multi-county entities, they have created a website that has links to every single health order from every single county or health department in the state, chronologically listed from the beginning of the response to the end of the response. And so as you're looking at, collating data from when you were given information, or when information was put out by your health department, and what did it say, this is a great resource to be able to identify where those things are, so that you can download them and keep them for your record keeping. So I've given you an example of a couple of the handouts that a couple of the reports that they send out. They're very long and detailed, and obviously they may not apply to all of us. or all of the things that they speak about may not apply to everybody, but there's some great information, and especially when we talk about doing after action reporting after this, those data points and those health orders are going to be important for you to be able to backfill information into your response. So that is, hopefully you guys find some value in being members there. Like I said, I have no other than being a member, I have no other association with those folks. I just get the listserv and I find them very helpful. So hopefully you find them helpful as well. All right. Vaccines on the horizon. First, I want to talk about one issue that I've heard about, and I don't know if this applies to everybody, but it's a lesson we can all learn, and we just want to give you the information so you can be prepared just in case this happens to you. But we've been told that on the second clinic, when Walgreens will come in, they're looking for those consent forms to be signed again. So consent form the first time, consent form the second time. Now, I don't know if that's true of all your experiences, but I do know that did happen to one facility, and because they could not get all the consents done by the time the folks were ready to leave, they missed out on a few people being vaccinated on their second dose. And we want to avoid that if at all possible. And certainly if you get Walgreens telling you that you can't use it, or CVS, or any experience like that, please reach out and let us know so that we can address it with the state. We don't have a good inroads with the folks at Walgreens and CVS. They've kind of been operating on an island, and they communicate with the state, but they don't necessarily communicate with us, sadly. So, but as we get that information, we'll pass it up to the state and say, here's the information we're hearing about Walgreens. Is this consistent? And if it is, can Walgreens please let every single person know that they talk to make sure this is done? So I would, if you're scheduled for your second Walgreens appointment and you've not done those consent forms, I would talk to my point of contact to make sure that's consistent. And if it is, if they want that second one, definitely get those consents done. All right, so vaccines on the horizon. Many of you guys saw in the news this morning, Johnson & Johnson announced a press release talking about the efficacy of their coronavirus vaccine. The good news on this particular vaccine, well, a few good things. One, it's a one-dose vaccine rather than 2 doses, which obviously makes administration a lot easier. Storage of the Johnson & Johnson vaccine is consistent with other vaccines. It does not have the ultra cold chain requirements that the Pfizer vaccine does, which also is good news for the ability to utilize existing pharmacy infrastructure to be able to support that vaccine. The efficacy in terms of reducing severe outcomes is not quite as good as the 2-dose Moderna and Pfizer vaccine, but after reading the press release, the Pfizer or the Johnson & Johnson was tested in countries with different variants that are thought to be more contagious. So it may be possible that the efficacy data is skewed by the fact that it's not as effective against certain variants of the coronavirus. And I think it's possible we may see that happen with Moderna and Pfizer. And I know Moderna and Pfizer both said they're going to develop booster shots to be able to deal with the new variant if necessary. So the Johnson & Johnson may already have that built in. And so as we look at the effectiveness of that, it may turn out to be just as good as the Moderna and Pfizer vaccine. We just don't know, since the Moderna and Pfizer were not tested, or that were not subject to those different variants. AstraZeneca is well along the way and very close to being completed with theirs, as well as Novavax. And Novavax is very promising because it is shown to be 89% effective in early trials. And it was also, all three of these had undergone trials in multinational country or many countries, not just the United States, to be able to monitor its effectiveness against various strains. And so those are all good news. None of these are saying they are going to prevent folks from getting COVID-19. What they're saying is that it's going to prevent severe outcomes from this, or severe adverse events. And the two are different. One, obviously, want to keep people out of the hospital, keep people alive. That's the main goal of the vaccine. What we're hoping for is that these vaccines also stop us from stop it from spreading. We just don't know that. And I think none of these new viruses will answer that question any better than the two that we currently have. They will allow us the opportunity to probably easier administration and more supply. And the more supply is probably the most important thing at this moment. Johnson & Johnson and Astra, both of those viruses use a cold virus like a Trojan horse in order to be able to do it. So they're designed differently than the current vaccines. They're slightly lower effective rates at preventing severe outcomes. One-shot dose, obviously, we talked about that. All of them seem to be preventing severe illness in that 80% and above range, which is good news. But none are guaranteed effective 100% for all variants. And like I said, we know Moderna and Pfizer are developing boosters for their vaccine. All right, I didn't have a ton of information to go over today. I think that's all we got today, and thank goodness for that. We don't have a ton of changes this week. So I have one question or one comment in the question box. They asked us for consents for each shot. We knew it in advance and had it done again. And family members were not happy with the additional complications of paperwork. Had to be a wet signature too, not e-sign. So that sounds, this is the second person I've heard that from. Now, they did not originally tell us that. Hopefully they made you guys aware of that beforehand. But definitely, this is enough information. I'll send a note over to the folks at the state to say that it's just not, we're just, wasting time doing that. You already got the signatures. So, all right. Any other questions from you guys? Because if we don't have questions, we have some work to do on our recovery planning. And I just want to let folks know as to kind of what we're thinking for recovery planning. None of this is in stone yet, and we've yet to make recommendations to the state. We hope to put pen to paper and have these recommendations to the state by the end of next week. But one of the things we're going to look at is in terms of vaccines and the ongoing vaccination of residents, both for new residents and anybody that decides now they want to get the vaccine, that we're not included in the pharmacy partnership. Our ask of the state is to utilize the existing pharmacy infrastructure network. Those folks they know exactly what they do. They do this all the time. We want to use those folks, and I've reached out to the Pharmacy Association to ask them, what are the barriers as a pharmacist? What are the barriers that you have to be able to do this? And obviously, the supply is number one. They just don't have supply, and once they get supply, that will solve that issue. But that's a pretty, an A and B formula. Either you have it or you don't. But in terms of capacity, they feel confident that even with the Pfizer vaccine, that the pharmacists throughout the state have the capacity and willingness to be able to do these vaccinations on an ongoing basis, regardless of the vaccine that's assigned to them. So that's fantastic news. I don't know if that's true of every pharmacist, but what I think CAF is going to make the recommendation is that we ask the state to activate every pharmacy in the state so that they have the ability to do vaccinations. And it's our responsibility to make sure that our pharmacy partners are going through the process to get signed up with CalVax. So if you've not talked to your pharmacist or pharmacy partner, ask them, have you guys signed up through CalVax and have you been activated? And if they've not been activated through CalVax, please have them email me directly, jbelden@caf.org, and let me know. We need to get all of these folks in the queue so that they could be set up to go once this pharmacy partnership is done. So anyways, that's kind of where we're going to go on vaccine. I don't think there's any other method that has the ability for us to stand up, whether it be mobile sites that go to you, with staff and other things like that. I just don't think there's staff. There's not resources out there in the community to be able to support these events, especially when we look at our sisters in long-term care, and we look at our other folks in assisted living and independent living that also their numbers are vastly larger than ours, and they have less resources than we do. And so as the community struggles with getting everybody vaccinated that they can, we think that it's probably appropriate that they utilize those resources to be able to support that mission, so long as we have our needs met through the existing infrastructure. And then when that fails, we'll have to, when or if that fails, we'll have to determine workarounds to that. But that's going to be our first recommendation to the state, is to utilize the existing resources and to get these folks all activated through CalVax and get them ready to distribute it. And then we'll talk to them about, kind of what do visitation look like? What is, activities within the building? What do those look like? I think our recommendations are going to be, probably pretty consistent, that we're going to have dedicated cohort categories for COVID positive folks. But we may see, folks in the green zone, if they've been vaccinated, requesting or recommending that they be able to have in-person visitation and be able to have group activities again. And some of those, there's some of these things that we may be able to carve out. We know the testing thing, and I've gotten a ton of questions on this. The testing is not going to go away, and it's probably not going to go away for at least a few months. And the reason being is, they're going to test each one of your folks that have had these vaccines when you get an outbreak, and then they'll go, oh, okay, well, it did not prevent this person from getting COVID. So we'll know that it's less effective in preventing spread, even if they are, even if they don't have symptoms or they don't struggle to recover from COVID. That's great news. The vaccine worked the way we wanted it to, but it did not work in the way that we hoped it would. So the CDC, CDPH, CMS is all going to be tracking that information. So it's unlikely we'll see that change probably for 2, maybe 3 months. It's going to take a while to get data to be able to make determinations of whether to make wholesale changes to things. So, and as quickly as they are to institute these really stringent measures, I think they're going to be that conservative to remove them. So as quick as they went in, that's how slow they will be to pull them back out. So, all right, we've got a couple more questions. I'm going to answer those, and then we'll go on. All right. So I noted that this is the last week schedule for these calls. We are going to schedule these. I don't know how much longer we'll keep them going. Definitely as long as there are still response activities to talk about, all the way through till when we get to after action reporting. And I think on our last webinar, when we wrap this up, we will do a presentation on how to capture information in an after action report that's going to get you through survey. And then we'll do some classes, I think, offline that won't be coronavirus. They're going to be like recorded sessions to get you guys through recovery. And that way they're not in a public forum, and we can talk about things like liability and protection from counsel, and we'll talk about Cal OSHA compliance and things like that that are not necessary to be on a statewide grant-funded webinar. We'll put those on a separate thing, but the plan is to continue these. I think we'll definitely schedule them out through February, and it's possible we could go into March or April. But yes, I'll get those dates added onto the calendar for you guys. So the next question is, has CAF tried to offer CEUs for these sessions? And I did at the beginning of the year for the first, 20 or 25 or so webinars. I did CEUs. I got to be honest with you, it became incredibly difficult because I have to apply for these CEUs 45 days in advance, and I can't really pick the subject matter 45 days in advance. It just became really, really difficult for me to do this. I will work on getting you guys some free CEs and credits this year. We'll try to do that. But with this particular modality, because I can't really pick the things, I don't want to get in trouble for adding material that I'm not actually covering in the slides. So I will bring you some free CEs sometime this year, I promise you. So, all right, PharmAmerica also told me that they will deliver individual shots to our facilities once they get availability to give new admits. Well, that's fantastic. That's good news from one pharmacy partner, and I spoke to another pharmacist this morning that said that they had to jump through quite a few hoops to get activated through CalVax, but now they're activated and they are actively doing vaccinations in skilled nursing facilities in Sacramento County. And they're supplementing, they're essentially going after the pharmacy clinic has expired. So that's great news. It sounds like from the pharmacy side, they're just waiting for the state to activate them in the CalVax system. But I don't know that the state has passed that information out to the pharmacists, or if they have, it's possible that they just haven't done that very well. And I just want you guys to make sure you have that conversation with your pharmacist to make sure that, especially if you use a mom and pop or a small pharmacy, ask them if they've gone through the CalVax sign up. And if they have and they're still waiting for activation, let us know so that we can follow up with that those folks at CalVax. And in terms of the list of pharmacies that are signed up, I have so somebody asked if a specific pharmacy was signed up in the questions, and I don't have data on how many pharmacies are signed up through that CalVax system. I suppose that I might be able to get the data from the state if I ask them for that, and we can verify that. I'll see if I can find the data, and I'll let you guys know on the call next week if I can find the data. So hopefully that answers all of your guys' question. Those are the two things that we're talking about, really making some rapid, quick changes. And then we continue to advocate, and we'll continue to advocate that at some point we're going to have to reduce or eliminate these daily and weekly reporting requirements. I don't think it's going to go away immediately, but I know how much time this adds to your guys' day. It's not, nobody thinks about this in terms of how much time it takes to do it, and it's completely unrealistic. But as we get opportunities to remove or eliminate some of those reporting requirements, we will advocate on your behalf. So I know that's, folks want to just get that nonsense out of the way, but I think we got some more time to dedicate to that. So, all right, guys, I want to say thank you. Thank you to Summer and Jamie for joining us today. Summer's going to take down all your questions, make sure I didn't miss any. And I'll get the information on the pharmacies that have already signed up through CalVax and been activated, and see if we can pass that out to everybody. So hopefully you guys have a great weekend. Take care. Sorry for the plane flying overhead, and you guys have a wonderful weekend. Thanks.